Hi guys, welcome everyone. Hope I am audible. So today we will be discussing or we will be learning how to identify arrhythmias on the ECG. Not a very difficult task per se, provided we stick to protocols, we will be always able to reach the diagnosis. Whenever we breach the protocol, we end up with the wrong diagnosis. Okay. So what are we going to do today? We will go through some images and try to decide whether they are normal sinus rhythm or they are arrhythmias. Now, to be able to do that, it is better that we go back to the definition of normal sinus rhythm and then come back to the topic. Okay. So let me take you through what we call as normal sinus rhythm. Normal sinus rhythm is a rhythm for which the pacemaker is the SA node, right? SA node is the pacemaker. That's why we're calling it as sinus rhythm. Plus, I'm adding a term normal behind it. To add normal behind it, I need the heart rate to be 60 to 100. And when SA node is the pacemaker, a wave of depolarization of course spreads along the atria and causes the atrial contraction, which will reflect in the form of P waves. So there should be P waves to call it as the sinus rhythm. To call it a sinus rhythm, there should be P waves. And these P waves should not just be present, they should be morphologically distinct and discrete. What do I mean by that? We can clearly be able to identify them as P waves. Not some ambiguous upstroke or a downstroke, but clearly identifiable P waves, and they should be normal. Now, what do I mean by normal P waves? The normal P waves are upright in most of the leads, right? The normal P waves are upright in most of the leads. They are upright and they are inverted only in two leads, inverted in lead V1, and they are biphasic, sorry, not V1, AVR, and they are biphasic in V1, right? Otherwise, upright in all other leads. So if I have to say that this is normal sinus rhythm, I should have an ECG where P waves are there. I can clearly identify them as P waves. They are looking like P waves, morphologically like P waves. And I will call it as normal P waves when they are upright in most of the leads, except in AVR where it can be inverted, and in V1 where it can be biphasic. Okay, then to call it as again normal sinus rhythm, there should be no blocks or any other hindrances. So when a wave is sent by the SA node, right, it will cause the atrial depolarization. There should be a P wave, but then because AV node is not blocked, the impulse will reach the AV node. AV node, after doing the necessary delay, it will pass the impulse down, and through his bundle branches and Purkinje fibers, it will cause ventricular depolarization. So there will be one QRS. After that, of course, ventricle repolarizes, giving me a T waves. So each P should be followed by a QRS. So in the ECG, if I catch hold of any QRS, behind that there should be a P wave, right? Or if I catch hold of a P wave, next to it there should be a QRS. Or in other words, I can say that if I take a ratio of P by Q, it should be 1. For every 1 P, there should be 1 QRS. So when all these criteria are met, then we will call it as normal sinus rhythm, right? Rate should be 60 to 100. Pacemaker should be SA node, that gives rise to a classical normal looking P waves. And each P is followed by QRS, or behind every QRS, there is a P. If these parameters are not met, then I will not call it as normal sinus rhythm. Okay, so with that backdrop, let's go back to the ECGs. And here is one ECG. I want you to now tell me whether I should count this as normal sinus rhythm or not. And if I'm not supposed to count it as normal sinus rhythm, what are the reasons for it? Why I should not count it as the normal sinus rhythm? Why it can't be normal sinus rhythm if you feel so? And if you feel yes, it is normal sinus rhythm, then fair enough. Okay, let me zoom in and show you. Okay, so number one, are there P waves present, morphologically distinct and identifiable? Do we have P waves in this ECG? Now, one of the biggest confusing factor for many students is how do I differentiate between P waves and T waves, right? Okay, so now just remember one thing. Whenever we have to identify rhythms, presence or absence of P waves is very, very important. But flattened T waves or absent T waves are relatively less common, particularly when we are thinking of an arrhythmia. So whenever such situation comes where whatever wave I'm seeing, whether I should count it as P or T, I'll give you a simple hack. What is the hack? See, the flattened T or absolutely absent T is extremely rare. Flattened T's are there, but you will still be able to identify a small T. Absent T's are almost rare. So in that case, I would presume that if ventricle was depolarized, it will repolarize, and if it repolarized, there should be a T. So every time I see a QRS, I have to attach one wave as T, right? If I am counting it as QRS, then the next wave I will count it as T. Apart from this, if I find any other wave which can I call as P, then I would say P is present, morphologically distinct and identifiable. If I don't find, I would say P is absent. So in this ECG, we can say that P is probably absent. That is a possibility. Okay. Then even if, let us say that, okay, I'm not very sure whether I should count this as T or P. Sir, whatever hack you gave, I'm not very comfortable with that. I will count it as P. Okay, agreed. Let us say that this is P. Now, what is the next criteria to call it as normal sinus rhythm? Each P should be followed by QRS. Behind every QRS, there should be a P. If I am counting these as P, it holds good, right? If this is a P, then it is followed by a QRS. Behind any QRS, there is a P. Okay, it still seems to be sinus. But what about the rate? To call it as normal sinus rhythm, the rate should be 60 to 100. So can anybody tell me what is the heart rate here? What is the heart rate? How do we calculate the heart rate? If the RR interval is regular, a quick calculation is 300 divided by number of large boxes between two sequential R waves, right? So how many large boxes are there between two sequential R waves here? It is around 1.6, right? 1.6 or 1.5. Let us take it as 1.5. If I take it as 1.5, 300 divided by 2 gives me 150 as the heart rate, right? 300 divided by 1 gives me 300 as the heart rate. So I can say that it is somewhere between 150 to 300 because I'm dividing it at 1.5. So if I take a proper calculation, I will come out with the absolute number. But for the exams, for day-to-day practice, I don't need. Okay, Kushi has mentioned it as 200. Good. So if it is 200, now can I call it as normal sinus rhythm? Can I call it as normal sinus rhythm? No, right? This is not normal sinus rhythm. What it can be? If the pacemaker is sinus, then it can be sinus tachycardia. If pacemaker is not sinus, it is one of the other arrhythmias, but this is not normal sinus rhythm, right? Okay, similarly, I will give you one more ECG. Go through it and tell me whether you count this as normal sinus rhythm or not. Okay, I will zoom in and show you the rhythm strip. Okay, so this is lead 2. Okay, is this normal sinus rhythm? Is this normal sinus rhythm? When do I call it as normal sinus rhythm? The pacemaker should be SA node. When SA node is pacemaker, we will get upright P waves in most of the leads except AVR and a biphasic in V1. Now, what do I notice here? It is an inverted P wave, right? This appears to be T wave. So then, where I am supposed to see a P, it is inverted, right? When I look at other leads also, I get an inverted P wave. In multiple leads, I'm getting inverted P wave. So what does that mean? Again, it is not a normal sinus rhythm. Here, the pacemaker is not SA node. If SA node is the pacemaker, I will get an upright P wave in most of the leads except AVR and V1. So that means this ECG is also not normal sinus rhythm. This is some arrhythmia. Now we will learn how to identify those arrhythmias. We have seen two ECGs. One this we counted it as not being normal sinus rhythm because of inverted P waves, not morphologically normal looking P waves. And this we considered as not a sinus rhythm because number one, the rate is not for the normal sinus rhythm range. Number two, we still have some speculation about whether these are T or whether these are P. So if I'm counting it as absent P, then of course it is not normal sinus rhythm. Okay, clear? Now these two ECGs have arrhythmias. We will learn how to identify these arrhythmias. Yesterday in the previous lesson, I have given you an approach. Whenever we have an arrhythmia, right, my next best step to differentiate is to see the QRS complexes, right? Whenever we have an arrhythmia, whenever we are suspecting a tachyarrhythmia, to be more precise, if I'm suspecting a tachyarrhythmia, the next thing I should see is the QRS complex or QRS duration. Based on that, we can classify the arrhythmias into two groups, the narrow complex tachyarrhythmias and wide complex. So if it is more than 120 milliseconds, that is 3 small squares, then we will call it as wide complex tachyarrhythmias. And if it is less than 120 milliseconds, then we will call it as narrow complex tachyarrhythmias. Now, what all comes under wide complex tachyarrhythmias? For an undergraduate students, there are only two differentials. One is VT and second one is ventricular fibrillation. There are rare circumstances, not important for us. If we are dealing with narrow complex tachyarrhythmias, right, the possibilities are, these are mainly supraventricular arrhythmias, right? Supraventricular arrhythmias when we say narrow complexes. So that includes sinus tachycardia, that includes atrial tachycardia. Within this atrial tachycardia, we have focal atrial tachycardia, multifocal atrial tachycardia, and atrial flutter. Then we have atrial fibrillation, and then we have paroxysmal supraventricular tachycardia, which can be of two types, AVRT and AVNRT, AVNRT and AVRT. Okay. So whenever I have an arrhythmia, what should be my first step? To decide whether the complexes are narrow or wide. Because if I get an ECG where, based on the definition of sinus rhythm, normal sinus rhythm, I've concluded that this is not normal sinus rhythm. I'm thinking of an arrhythmia. So when I'm thinking of an arrhythmia, the moment I check the QRS duration, some of the differential diagnoses become ruled out. If the QRS duration appears to be more than 120 milliseconds, so all these conditions are ruled out. If QRS duration appears to be less than 120 milliseconds, VT, VF are ruled out. VT, VF are ruled out, right? So keeping that in mind, we will go back to this ECG. Now look at this and tell me, are the complexes narrow here or broad? When do you call it as narrow? When from the beginning of Q to the end of S, it is all, the whole QRS complex is accommodated within 3 small boxes. How many small boxes it is taking here? It is taking 1, 2, 2.5 max, right? It is not taking more than 3 small boxes. So when it is not taking more than 3 small boxes, that means this patient, if I'm going to call it as an arrhythmia, this is a narrow QRS complexes, right? So this is a narrow complex tachyarrhythmia. Narrow complex tachyarrhythmia. Now what about this ECG that we were seeing? Is this a narrow complex tachyarrhythmia or is it a wide complex? Here also, it appears to be taking maximum 2 small boxes, right? This is the size of one large box. So from the beginning of Q to the end of S, it appears to take 2 small boxes. So that means this ECG also has narrow complex tachyarrhythmia, right? So then what are ruled out in both these ECGs? In these ECGs, VT and VF are ruled out, right? We are not thinking of VT or VF. We are thinking of other conditions. What are the other conditions? Sinus tachycardia, atrial flutter, atrial fibrillation, atrial tachycardia. Right? These are the conditions we are thinking of. Now we will see how to approach further. So whenever I have a narrow complex tachyarrhythmia, the next thing I should see is whether I have morphologically distinct P wave identifiable or not. In all narrow complex tachyarrhythmias, I should start looking for the P waves. If I have morphologically distinct P waves present, identifiable, if they are present, then my differential diagnosis are sinus tachycardia and atrial tachycardia. Okay. Now, how do I differentiate between these two? Atrial tachycardias. Atrial tachycardia will include focal atrial tachycardia, multifocal atrial tachycardia, and atrial flutter. And if morphologically distinct P waves are absent, then I have two differential diagnoses. One is atrial fibrillation and the other one is paroxysmal supraventricular tachycardia. Okay. So now, in these conditions, how will I differentiate? So primarily what I will see is, I will see the number of P waves and number of QRS. If it is sinus tachycardia, what does that mean? Pacemaker is SA node itself. So it is sending an impulse, AV node will catch it and pass it on to the ventricle. So one time atrial contracts, one time ventricle contracts. So the ratio will be equal. So if atrial rate is equal to ventricular rate, which is nothing but the number of P waves are equal to number of QRS complexes, number of QRS complexes. Then the possibility is sinus tachycardia, sinus tachycardia. But if atrial rate exceeds, atrial rate is higher than ventricular rate, ventricular rate, then it is suggestive of atrial tachycardia, atrial tachycardia. Okay, I hope the points are clear. So when I get a arrhythmia, I should first see whether it is narrow complex or broad complex. If it is narrow complex, I should see whether I can get morphologically distinct P waves. If I get morphologically distinct P waves, I will see the ratio of P and QRS, or atrial rate and ventricular rate. If both are equal, it is most likely sinus tachycardia. But if atrial rate appears to be higher than ventricular rate, then it is atrial tachycardia. It's there in the name, right? Why did we call it as atrial tachycardia? Because atrial rate is increased, ventricular is not equally affected. That's why it is called as atrial tachycardia. If ventricular rate gets increased more than atrial, we'll call it as ventricular tachycardia. Clear? Okay. Now in this atrial tachycardia, we had subtypes. What are the subtypes we had? Focal atrial tachycardia, multifocal atrial tachycardia, and atrial flutter. Now the only question is, how will I differentiate? Okay. Now atrial flutter is a condition where atrial rate is way higher than the ventricular rate. So the ratio is so skewed, like it can be 3:1. Like for 3 P waves, there will be 1 QRS. Again, for 3 P waves, there will be 1 QRS. Or it can be 4:1. In that case, there will be 4 P waves and then 1 QRS. Why that happens, I'll brief you. But what I have to see is whether atrial rate is higher than ventricular rate to call it as atrial tachycardia. So we'll go back to the ECGs that we had seen and decide whether it fits into any of these abnormalities, right? So let me take you through the first ECG that we had seen. This we agreed that it is narrow complex tachyarrhythmias, and whenever we are dealing with narrow complex tachyarrhythmias, whenever you see an upright wave other than QRS, right, try to label it as T waves, because absent T waves are rare. If ventricle is getting depolarized, it should get repolarized, right? The repolarization wave may be slightly flattened, but absolutely absent is rare. So if I have to label all these as T waves, right, do I have anything else in each complex to be labeled as P wave? I don't have. If I have, then I will label it as P, and then I would say P is present. But in this case, every complex I can get only one wave, which I have to label as T, and there is nothing else to be labeled as P, right? So then what should I count it as? I will count it as absent P waves, absent P waves. These are all will be labeled as P waves. And there is no other upright wave apart from the QRS and the so-called T waves. So that's why I will count it as absent P waves. Once the P wave is absent, can it be sinus tachycardia? No. Can it be atrial tachycardia? No. In those two conditions, P waves will be present. So what are my differential diagnoses now? When I have complexes which are narrow and absent P wave, my differential diagnoses are atrial fibrillation and paroxysmal supraventricular tachycardia. Okay. Now, how will I differentiate between these two conditions? Atrial fibrillation and paroxysmal supraventricular tachycardia. For that, I have to look at the RR interval. Whether this RR interval is remaining constant or it is varying from beat to beat. So if I have absent P waves, I have to look at the RR interval. And if the RR interval appears to be constant, then it is PSVT. If it has constant RR interval, then my diagnosis will be PSVT. PSVT. And if there is varying RR interval, from beat to beat there is variation, then we will make the diagnosis of atrial fibrillation. Atrial fibrillation. There are little more details to know about the atrial fibrillation and PSVT. As we go along, we will keep adding that. But first we will understand the approach. Okay, so let me summarize again. Whenever I get a arrhythmia, narrow or wide is my first step. Once I've decided that it is narrow, P wave is the next thing that I should be looking for. If P waves are absent, then I have PSVT and atrial fibrillation as my differential diagnosis. If P waves are absent, RR interval is constant, I will call it as PSVT. If RR interval is varying, we will call it as atrial fibrillation. Okay. So in this ECG, we have concluded that there are absent P waves. Now looking at the RR interval, what does it seem like? Is it constant or varying? Is it constant or varying? It appears to be constant, right? It is not varying from beat to beat. It is same in each beat. So I have constant RR interval. So then what is the diagnosis here? With a constant RR interval, that makes the diagnosis as paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia. So this patient has PSVT. Okay. Now let me also take you through another ECG and try to apply the same principle. Is this ECG having normal sinus rhythm? Okay. Let me zoom in to the rhythm strip. Is this ECG having normal sinus rhythm? Okay, so to call it as normal sinus rhythm, SA node should be the pacemaker, and if SA node is pacemaker, P waves will be present and they will be upright in most leads except AVR, and it can be biphasic in V1. Okay, so in AVR there appears to be a negative P wave, but P waves are present and identified, because if I catch hold of any complex, one wave I will label it as T, and do I find another wave to be labeled as P? Yes, it is there. So that means P waves are present, right? Okay, so in this ECG, P waves are present. They are upright in most leads, so they are morphologically normal. So what does that mean? The pacemaker is SNA. Okay, now rate has to be 60 to 100. So what is the rate here? What is the rate here? Okay, so this is one large box, two large box, three large boxes between RR intervals. So rate appears to be around 100. Rate appears to be around 100. So here P waves are present and the heart rate appears to be 100 per minute. So keeping that in mind, can I call it as normal sinus rhythm? Yes, P waves are present. They are morphologically normal. They are upright in all the leads except the AVR. And rate is also perfectly fine. And if I catch hold of any P wave, next to it, I find a QRS. If I catch hold of any QRS, behind it, I find a P. So that means this ECG is normal sinus rhythm. There is no arrhythmia, right? P is followed by QRS or vice versa. So that means this patient is not having any arrhythmias. This is normal sinus rhythm. Normal sinus rhythm. If my calculation had, like, all the findings were same, but if my calculation had showed that the rate is 120, then I would have called it as sinus tachycardia. If my calculation had showed heart rate to be 40, I would have called it as sinus bradycardia. Now with the heart rate in the perfectly normal range, this is normal sinus rhythm, right? Okay. Now let us look at one more ECG and try to apply the same principles that we have followed. This is just the rhythm strip here. Just the rhythm strip here. Now the question is this normal sinus rhythm or not? To call it as normal sinus rhythm, I have to find morphologically distinct P waves, right? Do you find morphologically distinct P waves? I've given you a simple hack. Whenever you catch hold of a complex, if you see one upright wave other than QRS, first try to call it as T and see if you find anything else to call it as P. Okay. So let us say that I'm catching hold of this complex, right? So next to it, I find some wave, but I have to call it as T. So if I call it as T, is there anything morphologically clearly looking like P? No. Okay. If I catch hold of this QRS, I see something upright, so I will call it as T. Do I find anything else to be called as P? No. Right? So that means this patient has no P waves, right? No P waves. That means this is not normal sinus rhythm. This is some arrhythmia. And once we have concluded that this is arrhythmia, what is our next step? To know whether the complex are narrow or wide, right? So when I look at it, the QRS is taking barely how many small squares? Little more than 1. That means the complexes are narrow. So here I did not get P waves, so that's why I have not called it as normal sinus rhythm. This is an arrhythmia, and if it is arrhythmia, we have to divide it as narrow complex or wide. This is narrow complex tachyarrhythmia. Once it is narrow complex tachyarrhythmia, the next thing I should see is P waves are present or absent, and we just agreed that P waves are absent in this ECG. Once the P waves are absent, I have mainly two differential diagnoses. First is PSVT and the second one is atrial fibrillation. So what should be my diagnosis here? If it is PSVT, the RR interval remains constant. But in case of atrial fibrillation, the RR interval keeps varying. So here, is it constant or varying? Of course, it is varying, right? It is too large here. It is relatively small. So we have varying RR interval. Varying RR interval. So that makes the diagnosis of this ECG as atrial fibrillation. Then some of you may be wondering, sir, there are some baseline undulations on this ECG, right? What are those? Well, whenever your teacher in the medical college has taught you about atrial fibrillation, what did he tell you about atrial fibrillation? Atrial fibrillation is a condition where atria is merely vibrating or shaking. It is not able to contract. When atria contracts on the JVP, it produces a A wave. On the ECG, it produces a P wave. That is a wave of atrial depolarization, right? Here in atrial fibrillation, basically what happens is, in atrial fibrillation, if this is my heart, right? So in atrial fibrillation, especially points where pulmonary veins join the left atrium, around this, multiple ectopic triggered activities are generated, or ectopic foci, which start acting as pacemakers. So they start firing electrical impulses to go across the atria and cause the atrial depolarization. But the voltage generated by this ectopic pacemaker is much inferior to the voltage generated by the normal sinus rhythm. So with this amount of voltage, the atria can only afford to shake a bit, not contract. If I give sufficient voltage, then it can contract, but I'm not able to generate that voltage. I'm giving inadequate electrical impulses. So with that, it only starts shaking. So now atria is vibrating. It is vibrating. It is not able to contract. This condition is what we call as atrial fibrillation. Now, if this ectopic focus is sending a wave of depolarization across atria, it should reflect on the ECG, right? Yes, it is reflecting on the ECG as these small upstrokes or undulations. So all these small undulations that you see, these are nothing but electrical impulses fired by this ectopic focus, but they are not sufficient enough voltage to cause atrial contraction. So at this voltage, atria can only afford to vibrate. That's why it is only shaking. It is not contract, right? Now these waves that we are getting as baseline undulations, we will call them as fibrillatory waves, or F waves, or fibrillatory waves. So all these baseline undulations will be called as fibrillatory waves. Fibrillatory waves or F waves. Okay, I hope the point is clear. So now we know how to identify PSVT and atrial fibrillation. In both the cases, clearly identifiable P waves are not there. But in one case, the RR interval is constant, that is PSVT. In atrial fibrillation, the RR interval keeps varying. Okay. Now, coming back to this algorithm, if I get morphologically distinct P waves, I can have sinus tachycardia or atrial tachycardias. Okay. So in case of sinus tachycardia, atrial rate will be equal to ventricular rate. But in case of atrial tachycardia, generally atrial rate is higher than ventricular rate, especially if I am dealing with multifocal atrial tachycardia or atrial flutter. But in case of focal atrial tachycardia, atrial rate may be same as ventricular rate. Atrial rate will be same as ventricular rate. So we'll now learn how to differentiate between these conditions where P waves are morphologically distinct and identifiable. Morphologically distinct and identifiable. How do I identify multifocal atrial tachycardia, atrial flutter, sinus tachycardia, and focal atrial tachycardia? Okay, so one way is looking at P by Q ratio, or another way is calculating the atrial rate and ventricular rate. Now, how do I calculate atrial rate and ventricular rate? What is the wave of atrial depolarization? P wave, right? What is the wave of ventricular depolarization? QRS complex. So when we calculate heart rate in general, right? When someone asks you what is the heart rate, we are actually calculating ventricular rate, because When ventricle contracts, a pulse is generated, right? That is significant. That is what clinically it is relevant. But if I have to calculate atrial rate, I can follow the same formula. Only thing that I have to keep in mind is that I have to look at the, instead of RR interval, I have to look at the PP interval. I have to look at the PP interval that gives me the atrial rate. Okay. So can we calculate atrial rate on this ECG? PP interval, right? So atrial rate is calculated by atrial rate is equal to 300 divided by number of large boxes between PP interval. Okay, so when I look at this, right, this is one large box, two large box, here three large box and three large box, and so roughly we will take it as 3. So in that case, atrial rate becomes 300 divided by 3, which is equal to 1. And what is the ventricular rate? Ventricular rate also is roughly 3 large boxes. So ventricular rate is equal to 300 divided by 3, that is also 1. So that means in this ECG, atrial rate is equal to ventricular rate. So what are the possibilities in that case if atrial rate and ventricular rate are same? Sinus tachycardia or focal atrial tachycardia. Focal atrial tachycardia. Now I will go with the diagnosis of sinus tachycardia here. Why? Because the P waves are clearly looking like normal P waves, right? They are upright in most leads except AVR. But same picture, atrial rate is equal to ventricular rate, but P wave does not look like morphologically normal P wave. It is different looking. Then I will call it as focal atrial tachycardia. Focal atrial tachycardia, right? Let us take one more ECG example. This is the ECG that we were dealing earlier. We concluded that this is not normal sinus rhythm because the P waves appear to be inverted, right? But we notice that the complex are narrow, so we have to think of narrow complex tachycardias. And here, because I have a discrete, morphologically distinct, identifiable P wave, not in normal shape, but I can call this as P wave. So we will count it as P wave being present. P wave being present. And when I have narrow complex tachycardia with P wave being present, I have atrial tachycardia, sinus tachycardia as my differentials, right? Now, what is it? We will decide. Now, if I have to calculate the ventricular rate here, 1, 2, 3, 3.5, right? So 300 divided by 3.5 gives me my ventricular rate. And if I have to calculate the atrial rate, then I have to look at the PP interval, right? This also appears to be 3.5, right? 300 divided by 3.5. I don't know what value will come out, but whatever is the value, both are equal. Atrial rate is equal to ventricular rate. Atrial rate is equal to ventricular rate. So according to our algorithm, if atrial rate is equal to ventricular rate, either I have sinus tachycardia or focal atrial tachycardia. Now in this ECG, I can't call it as sinus tachycardia because these are not morphologically normal P waves. They are not morphologically normal. So then what should I call it as? I will call this ECG as focal atrial tachycardia. Why is it called as focal? So when I look at these P waves, right, they're all looking same, inverted. Catch word of any other lead, they're all looking same. That means from whichever source this arrhythmia is originating, it is only one source. It is only one source. That's why it is called as focal atrial tachycardia. Atrial tachycardia, some part in the atria has become a pacemaker. It is not SI node anymore, but it is only one focus. That's why all the P waves look same, right? So here P waves are present, but they are not morphologically normal, right? They are inverted in all leads except, of course, AVR will have a different polarity except AVR, and they are morphologically similar. They are not different looking, right? They are morphologically similar. So keeping those points in mind, we will make the diagnosis of focal atrial tachycardia. Focal atrial tachycardia. Just to give you an example, right? Let us say that this is the atrium that we are talking about. This is the ventricle. Now normally SA node should be the pacemaker, but here let me say that one extra tissue here has become the pacemaker, and it is now sending the wave of depolarization. So it will send the wave of depolarization through the AV node down to ventricles, giving me the QRS complexes. But the direction of flow of electricity to the atria normally should have been from SA node downwards and towards left, right? That gives me the upright P waves. But here it is in the opposite direction, right? From down to upwards and from left to right. So instead of giving me a positive P waves, I'll start getting the negative P waves, right? That's why I had negative P waves in the ECG. So that means there is one extra focus which is generating the arrhythmia here. Arrhythmia here. Juice Khan, I will tell you that. Okay, so I will just address this. So now we are going to call this as focal atrial tachycardia. Why am I calling it as focal? Because only one focus is acting as the pacemaker. But let us think of another situation where multiple areas in the heart become pacemakers in the atria. One more here, okay, and then I have one more here. So one time the atria get depolarized because of the impulse generated by this pacemaker that gave me a negative P wave, right? Another time this pacemaker sends the wave of depolarization across the atria. Now do you think both the P waves will look same? No, they are going to look different, right? The third time this pacemaker generates the impulse. So will it look like the impulse generated by the earlier two pacemakers? No. Fourth time maybe normal sinus node generates the pacemaker. Will it look like the other three P waves? No. So if I have more than one focus pacemakers in the atria, then my P waves will start looking different. So in any ECG, if I find more than or equal to three distinct P wave morphologies, in a narrow complex tachyarrhythmias, then we will call that ECG as having multifocal atrial tachycardia or MAT. Multifocal atrial tachycardia or MAT. There is some particular important MCQ point about this MAT. MAT is classically seen in patients with COPD. In fact, it is considered as the pathognomonic arrhythmia of COPD. Pathognomonic arrhythmia of COPD. Means it is not usually seen in non-COPD patients. So if I get a non-COPD patient with some palpitations, I may not be thinking of MAT as a possibility. But if I get a COPD or a long-standing smoker, MAT is one of my differential diagnosis, right? So how MAT is different from the focal atrial tachycardia? The main thing is that in focal atrial tachycardia, all the P waves look same, morphologically similar. But in case of multifocal atrial tachycardia, because there are multiple foci, all the P waves are not going to look same. So to diagnose, I need to identify at least three P waves which are not looking same. They are looking different. One is upright, one is inverted, one is tall. Okay, three different shapes. Then it is multifocal atrial tachycardia. Okay. Now going back to the ECG. So now we know how to identify sinus tachycardia, focal atrial tachycardia, and multifocal atrial tachycardia. Sinus tachycardia, atrial rate is equal to ventricular rate, or number of P's is equal to number of QRS. Each P is followed by a QRS. Behind the QRS, there is a P. Only thing is, it is different from normal sinus rhythm in the form of heart rate being more than 100. In focal atrial tachycardia, each P is followed by a QRS. So number of P is equal to number of QRS, or atrial rate is equal to ventricular rate. But the P is not morphologically normal. It looks different because it is not coming from the SA node. It is coming from an ectopic focus in the atria. So that is how we diagnose it. Okay, now the only pending thing is atrial flutter, right? How do I recognize atrial flutter? Atrial flutter is a form of atrial tachycardia where atrial rate is way more than ventricular rate. Sometimes it is so high that it can create undulations on the baseline resembling the sawtooth. That's why it's classically called as sawtooth appearance. When I show you an ECG, probably you will be able to relate to it. Now look at this ECG. We will not skip any of the steps. We will follow the steps so that, because I know you will see this sawtooth and jump to say that's a atrial flutter. But this jumping to make diagnosis in arrhythmia sometimes can take us to the wrong diagnosis. So we will not skip any of the steps. Okay. So first thing, is it normal sinus rhythm or not? The answer is no, this is not normal sinus rhythm. Why this is not normal sinus rhythm? Because in normal sinus rhythm, if SA node is a pacemaker, P wave should be present. In this case, yes, P waves are indeed present. Because if I take any QRS complex, one of the upright wave other than QRS can be T, right? If I label this as T, what are the remaining things? If this is T, what are these? Of course, I have to call them as P waves. So P waves are present. P waves are present. But then why is it not sinus rhythm? Because normal sinus rhythm should have one P followed by one QRS. Behind a QRS, there should be a P. Okay. So now if this is T, then this has to be P. And then a P should be followed by QRS. But instead I'm getting one more P, right? One more upright wave. Then I get a QRS. Okay. If I label this as T, then these should be P. So here P is not followed by QRS, right? All of you agree? Each P is not followed by QRS. Only few P's are followed by QRS. This P is followed by QRS, not these P's. So in that case, can I clearly say that the number of P waves are more than the number of QRS complexes? Number of P waves are more than the number of QRS complexes, right? Or in other words, we can say atrial rate. Atrial rate is greater than ventricular rate. If you want, we can calculate also. What is the atrial rate? Number of large boxes between the two P waves, right? If these are two P waves, I have one large box. So atrial rate here is 300 divided by 1, which gives me 300 as the atrial rate. And what is the ventricular rate? Ventricular rate is 1, 2, 3, 4, 4.5, right? 4.5. So 300 divided by 4.5, 4.5. I don't know how much it comes. If 300 divided by 5 is the number I'm looking at, it gives me 60. It is little more than 60. Somewhere between 50 and 60. Just give me a rough number when you calculate using the calculator, so that I can document here what is the ventricular rate. So meanwhile, I'll address Juice Khan's query. Why atrial fibrillation have pulse deficits? Okay, so there are multiple mechanisms behind why pulse deficit. First of all, those who don't know what is pulse deficit, let me explain. What is pulse deficit? Pulse deficit refers to difference between heart rate and pulse rate. Heart rate and pulse rate. Now, what is heart rate? What is pulse rate? Pulse rate is calculated by looking at the pulse, palpating the pulse. Heart rate is calculated by auscultating the heart. Now, in atrial fibrillation, what happens? In atrial fibrillation, there are many ineffective contractions of the atria, right? Like, because I'm not generating sufficient voltage for the atria to contract if this is my atria. So ventricular rate is 66, right? Let me label it as 67. These are precise numbers, 67. So can I say that atrial rate is more than ventricular rate? Yes, of course, right? Okay. Now I'll come back to this ECG. So in atrial fibrillation, what happens is the atria is not contracting. It is merely vibrating or shaking. So when it is doing that, right? When you see that ECG, when you see the atrial fibrillation ECG, you can understand. I did not get morphologically clear distinct P waves, but I had some baseline undulation, right? Some electrical activity happening at the atria. So some of these electrical activity may have some reasonable voltage for the atria to generate some degree of contraction. Some of them are absolutely ineffective. Atria just shakes. Okay. So then in that case, ventricular filling keeps varying. The ventricular filling is not constant. When atria generates some degree of contraction, see, when we fill the ventricle, we do it in two stages. One is called as passive filling and the other one is called as active filling. Passive filling accounts for 70 to 80% of the blood that fills the ventricle, and active filling accounts for 20 to 30% blood that fills the ventricle. In atrial fibrillation, what is my loss? Active filling is not happening because atria is not contracting. It is only passive filling that we are dependent on. So ventricular filling is as such reduced. It is as such reduced. Okay. Now, second problem that happens in atrial fibrillation is, as we have seen, the RR interval, it was varying. That means the ventricular rate is varying, it is not constant. So when ventricular rate is varying, sometimes ventricle contracts successively, quickly. Sometimes it is taking longer time to contract. Like look at this ECG. Here it contracted with very minimal gap between the previous ventricular ejection and this ejection, right? But between this ejection and this ejection, there was huge gap. This gap is important because during this period, after ventricle contracted, the filling of the ventricle is happening during this period. So during this period, less time was there to fill the ventricle. During this period, more time was there to fill the ventricle. So when I have less time, less filling, so the stroke volume generated will be less. So first of all, active filling I am losing, I am dependent on passive filling. Within that, there are multiple times where there is decreased stroke volume because of less filling, and there are multiple times where there is relatively normal or relatively higher stroke volume because of more time available for the filling. So when I measure the pulse, when the stroke volume was very low, will I be able to feel this pulse? As a human being, I may not be able to appreciate a very small volume pulse. But when I have relatively higher stroke volume, this pulse I can feel. But every time ventricle contracted, I will have heard the sounds. So this will also be measured as a heart rate. This will also be measured as a heart rate. So my heart rate will appear to be higher in comparison to my pulse rate, right? I am missing out on feeling some of the pulses because of those small stroke volume. Like if I see this ECG, as a human being, probably this pulse I might not have felt because filling time was very less. So this time the ventricle was not well filled. So the amount of stroke volume, see, when I fill the ventricle, whatever blood is there in the ventricle at the end of it, I will call it as end diastolic volume. So end diastolic volume was low. Out of that, 60% is my ejection fraction. So I'm going to eject only 60%. So here the stroke volume will be significantly low. So this pulse I may not be able to feel. But here I have given sufficient time for the ventricle to fill. This pulse I will comfortably feel. But both of them I will hear as heart rates. Because valves will close, they will produce a sound, I will hear it. So heart rate appears to be higher in comparison to pulse rate. In a perfectly normal individual, my heart rate and pulse rate should be almost equal. So I should not have a great difference between them, right? It should be less than 10. But in atrial fibrillation, it will be more than 10 because many of the ventricular ejections were of low stroke volume, which we cannot feel as the pulse. I hope you got the answer. Okay. So now coming back to this ECG. So in this ECG, atrial rate is more than ventricular rate, right? Atrial rate is 300 and ventricular rate is, let me keep it more simple, 65, right? Or more closer, quicker, simple number, let me call it as 60, right? So then can I call this as normal sinus rhythm? Of course not. It is not normal sinus rhythm. I have P waves, but P is not, all the P's are not followed by QRS. So that means it is not normal sinus rhythm. So when it is not normal sinus rhythm, it is an arrhythmia. And when we have an arrhythmia, the next step we see is the QRS duration. The QRS duration appears to be narrow. It takes 3 small squares here. So we'll count it as narrow complexes. And once I have narrow complexes, my differential diagnosis include sinus tachycardia, atrial tachycardias, atrial fibrillation, PSVT. So next step is always to look for P waves, which we already know P waves are there. So this is not atrial fibrillation. This is not PSVT because in both those cases P waves will be absent, right? This has to be either sinus tachycardia or one of the atrial tachycardia. This is not to be called as sinus tachycardia because the number of P's are more than the number of QRS. So sinus tachycardia is ruled out. I'm not going to call it as focal atrial tachycardia again because focal atrial tachycardia, atrial rate, ventricular rate will be equal. I'm not going to call it as multifocal atrial tachycardia because all the P waves appear morphologically similar. It is not like one is inverted, one is upright, one is tall, one is small. All the P waves appear to be morphologically similar. So then from my algorithm, almost everything else is ruled out. This is not sinus because P is more than QRS. This is not focal atrial tachycardia again because P is more than QRS. And then it is not multifocal atrial tachycardia because P has similar morphologies. There are no 3 distinct P wave morphologies. So I'm left with atrial flutter as the diagnosis. Just to confirm that I'm dealing with atrial flutter, I have to look at mainly inferior leads. Inferior leads. So in the inferior leads, multiple P waves can give rise to the appearance of the sawtooth. And all of us know a saw, and it looks like the sawtooth. It may not, it may be less distinct in other leads. It may be less distinct in other leads. That's why we should look at the inferior leads. And when I look at inferior leads 2, 3 AVF, I can clearly imagine a sawtooth, right? Why I'm getting this sawtooth? Because P waves are way more than the QRS. So multiple P followed by one QRS giving rise to the sawtooth appearance. So there is sawtooth appearance. So all these findings put together and sticking to our algorithm, we are coming to the conclusion that this is atrial flutter, which is a subtype of atrial tachycardia. Atrial tachycardia. And whatever ECGs we have seen previously, right? None of them had reached the atrial rate of 300. Here we are reaching the atrial rate of 300. Okay. Now, we'll just take a quick look at the algorithm one more time before we discuss the management of these arrhythmias. So whenever I have an ECG where I have to identify whether there is an arrhythmia or not, I have to remember what is normal sinus rhythm. To call it as normal sinus rhythm, SI node should be the pacemaker. That means P should be there. They should be morphologically distinct and normal. And a normal P is upright in all leads except AVR, and it can be biphasic in V1. And heart rate should be 60 to 100. Each P should have a following QRS, or behind the QRS there should be a P. So when all these parameters are met, it is normal sinus rhythm. If these parameters are not met, it is an arrhythmia. It is an arrhythmia. So when these parameters are not met, my next step is to classify. If these are not met, it is arrhythmia. Now I have to classify the arrhythmia as narrow complex tachyarrhythmia or wide complex tachyarrhythmia. So for that, I have to look at the QRS duration. If it is more than 120 milliseconds, VT and VF are my differential diagnosis. If it is less than 120 milliseconds, then all these narrow complex tachyarrhythmias are my differential diagnosis. Once I encounter a narrow complex tachyarrhythmia, I should look at the P waves. If I can find morphologically distinct P waves where I can confidently say that this is P, then I have differential diagnosis of sinus tachycardia, focal atrial tachycardia, MAT, and atrial flutter. And if morphologically distinct P waves are absent, I have a differential diagnosis of PSVT and atrial fibrillation. So when I have identifiable P waves, I have to calculate atrial and ventricular rate. If they match, atrial rate is equal to ventricular rate, or number of P waves and number of QRS complexes are equal, then it can be sinus tachycardia or focal atrial tachycardia. To differentiate between the two waves, two conditions, I have to see the nature of P waves. If P waves appear to be normal, right? If P appears to be normal, then it is sinus tachycardia. If P wave appears to be morphologically not normal, then it is focal atrial tachycardia. If atrial rate is higher than ventricular rate, the other atrial tachycardias, that is MAT and atrial flutter, are my differential diagnosis. In MAT, I will have more than or equal to 3 distinct P wave morphologies. And in atrial flutter, all the P waves will appear same. And of course, atrial rate is more than ventricular rate. And because atrial rate is more than ventricular rate, I may have the sawtooth appearance, especially more distinctly visible in lead 2, 3 AVF, the inferior leads. That is how we make a diagnosis of narrow complex tachyarrhythmias. And if it is absent P waves or not morphologically distinct P waves, then I have to see the RR interval. If it is constant, it is PSVT. If it is varying, it is atrial fibrillation. So to just quickly glance through the ECGs, this was one of the ECG where rate was definitely more than 100, because it is taking only 1.5 or a little more than 1.5 small squares. So rate is more than 100. It is more than 150. Okay, and P waves were absent and the complexes are narrow. So keeping all that in mind, we made a conclusion that this is PSV, right? Arrhythmia is there because P waves are absent. It's not normal sinus rhythm. Once the P waves are absent and we have concluded that this is an arrhythmia, we looked at the QRS. QRS is narrow, so we are applying the narrow QRS algorithm. In that case, we see the P. Again, P is absent. So atrial fibrillation and PSVT were my differential diagnosis, and constant RR interval makes it as PSVT. In this ECG, P waves were present, morphologically distinct and identifiable. The number of P and number of QRS was equal. So keeping all those points in mind, and the heart rate also appears to be within the normal range of 60 to 100. So we concluded that this is normal sinus rhythm. Okay. In this ECG, we concluded that this is arrhythmia because P waves are absent. So it is not normal sinus rhythm. And once it is arrhythmia, we applied the algorithm. It is narrow complexes. So we'll follow the narrow complex algorithm. According to narrow complex algorithm, the next thing we should see is P present or absent. Of course, it is absent. So when it is absent, PSVT, atrial fibrillation, or a differential diagnosis with varying RR interval, we call it as atrial fibrillation. Okay. And in this ECG, again, we concluded that this is arrhythmia, not normal sinus rhythm, because P waves are there, but the number of P, each P is not followed by QRS. There are a lot of P waves which are not followed by QRS. So based on that, we decided that this is an arrhythmia. Then once it is an arrhythmia, we again applied the arrhythmia algorithm. The complexes are narrow, they are not wide. So we will follow the narrow complex tachyarrhythmia algorithm. And when it is narrow complex tachyarrhythmia, again, the next question is P wave are present or absent. P waves are of course present. The next thing is atrial rate is equal to ventricular rate, or atrial rate is more than ventricular rate. So here atrial rate appears to be more than ventricular rate. There are a lot more P waves than QRS complexes. Right? So when atrial rate is more than ventricular rate, we had MAT and the atrial flutter as my differential diagnosis. And because all these P waves appear similar, we are coming with the conclusion that this is atrial flutter. Clear? Okay. So once we have made the diagnosis of narrow complex tachyarrhythmias, the next thing is how do we manage them? So we'll take individual approaches, but I'll tell you some basic rule. Rule is what? If you ask me, sir, what is the best treatment for an arrhythmia? What is the best treatment? Like I have drugs, I have physical maneuvers, and I have a cardioverter defibrillator machine. Out of these three, what is the best treatment? And I have last one. That is doing the electrophysiological study, identifying where is the ectopic pacemaker situated and ablating it. Right? 4 options for any arrhythmias. One is drugs, then physical maneuvers like stimulating the vagal nerve, physical maneuvers, drugs, cardioversion or defibrillation, that is shock, defibrillation, that is shock, and then electrophysiological studies to identify where exactly which tissue is becoming an ectopic pacemaker, or it is becoming a re-entry circuit, and ablating it, right? EPS and ablation. Okay. So the definitive treatment is the EPS ablation, because identify the root problem. Like for example, we discussed AV NRT yesterday. So in AV NRT, what happens? In the AV node, there is a fast conducting pathway and a slow conducting pathway. So sometimes what happens, the electricity, because fast conducting has a longer refractory period, the electricity loops through slow conducting pathway, goes back to the atria and goes to the ventricle. So it causes an additional depolarization of the atria and ventricles. That is how we get AVNRT, which is nothing but one type of paroxysmal supraventricular tachycardia. So if I can identify this, right, I can ablate this slow conducting pathway. Once I have ablated it, then there is only one pathway for the impulse to go down to the ventricle. There is no re-entry possible. Right? In atrial fibrillation, around the point where pulmonary veins enter the left atrium, right, some tissue becomes an ectopic focus, which is generating the wave of depolarization for the atrium. So if I ablate it, if I causes damage to it, then no longer it will be able to generate an extra pacing, right? So this is the definitive treatment, but this is not required for all patients. Many patients will be able to manage with drugs, maneuvers, or cardioversion defibrillation. So this is required for mainly those patients where the pathology persists or recurs again and again. So among these, for someone who is presenting to me for the first time with an arrhythmia, what should I choose? What is the best? Among these, for an acute management, cardioversion or defibrillation or shock is the best treatment. Shock is the best treatment. Shock is the best treatment. But of course, we will not go for shock for all patients. The best treatment is reserved for those who are either hemodynamically unstable or those who are not responding to drugs and physical maneuvers. Because shock is little cruel. Means we need to sedate the patient and then give shock, right? We can't give shock to an awake individual. This is cruel, inhuman. So we don't need to jump to do the cardioversion or defibrillation for all patients, but we should remember that this is the best for converting the rhythm to normal when it comes to acute setting. For prevention or long-term management, electrophysiological study and ablation is the definitive treatment. Okay. Now I have a question. Why do we give shock? Before we discuss individual management, why do we give shock? Is there any reason we give shock? Like, let me give you a scenario, right? You are in a hospital and in front of you a patient and his ECG looks like this, flat line, right? This is what in medical terms we call it as asystole or asystole. Should I shock this patient or not? If you are the treating doctor, will you shock this patient or not? Would you give shock or no? In front of me, if there was some ECG activity happening, then it became flat line. Should I now give shock or not? We'll come back to arrhythmia later, but this is a very important point for us to understand. How many of you would like to give shock for this patient? How many of you would like to give shock? Yes or no? Okay, so there's a point to understand here, very, very crucial, and I hope like today you will take home a very important message which will save hundreds of deaths from your hand. I strongly believe that many of the times doctors are responsible for some avoidable deaths, and one of them is doing this mistake. All of us imbibe more medical knowledge by watching TV and Instagram than from the books or from the real teachers. In the movies, ECG flatline, then someone gives a shock and the patient wakes up. Okay, so, now tell me, for what purpose you want to give shock? Is it to stimulate the heart? If you're thinking that it stimulates the heart, you're absolutely wrong. In that case, if I put my finger in the electric socket, right, it should stimulate my heart, right? My heart should contract now with more force and I should feel more energetic. So before going to gym every day, I should do that and go, right? No. If I put my finger in the socket, I can die. Why do I die? Because my heart stops. My heart stops. So when we give shock with the aim of stopping the heart, not stimulating it. So when someone gets this ECG picture, this is a non-shockable rhythm. We are not supposed to give shock because already heart is stopped. By shocking him, I make sure that it stays stopped, right? His chances of whatever little chances of recovery he had, I'm taking it away by giving him shock. So then again, why are we giving shock? Why it is effective in treating arrhythmia, right? We'll understand that today. So when there is an arrhythmia, right, there is some ectopic focus, like let us say here, there is an ectopic focus which is generating an arrhythmia, which is overpowering my normal conducting system, the SA node, AV node and all, and this is taken over the rhythm. When I give shock, right, the electricity passes through heart. As it passes through heart, it silences all the electrical activity of the, it stops, literally stops the SA node, stops AV node, His bundle, Purkinje fibers, myocardial cells, and the ectopic focus. Everything is stopped. Okay. Now, as the electricity passes away, the heart will try to bounce back. Now, you should only tell me, between this ectopic focus and SA node, who has a higher chance of early recovery and taking over the rhythm? Who has higher chance? It is SA node. Why? Because SA node is designed to be the pacemaker. This ectopic, either because of the influence of drugs or some other reason, had become a pacemaker. It is not designed to be pacemaker. This tissue is not pacemaker. It was acting like pacemaker in the absence of or because of some stimulation. And once I stop everything, the chances of recovery and taking over the rhythm is higher for SA node. So this will probably get suppressed and SA node will take over the rhythm. Now I will have the normal sinus rhythm. So the concept is same as when your phone hangs, what do? You switch it off with the hope that when it switches on, whatever bug or an cranky app which was responsible for hanging of your phone will be finished and your phone will open normally. Same hope, we are giving the electricity to silence the whole heart so that when recovery happens, hopefully normal pathways recover ahead of the ectopic focus, and that is how the normal sinus rhythm can be re-established. But if heart has already stopped, giving more shock means we are silencing it further, right? So chance of recovery comes down. So that's why in anesthesia they teach you there are two rhythms which are non-shockable. One of them is asystole or flatline. The second one is pulseless electrical activity. In these two cases, we should not give shock. But unfortunately, even today, a lot of hospitals, when someone arrests, they give shock. And by giving shock, we are taking away whatever little chance of this patient had for recovery. So then you may ask a question, sir, if a patient is arrested, then how can I make him recover? Can CPR make him recover? Can CPR make a person whose heart has stopped, he is in asystole, recover? Pumping the chest, will it recover? No, absolutely not. Then why are we giving CPR? Again, there's a misconception among medical students that we give CPR to stimulate the heart. No, we are not giving CPR to stimulate the heart. Few things are well established that they cannot stimulate the heart. Your physical compressions do not stimulate the heart. A loud one coming and touching the patient like you see in the movies does not stimulate the patient's heart. It only happens in the cinema, not in reality. Someone shouting the patient's name does not stimulate the heart. Once heart has gone into asystole, we have to identify the underlying cause and treat it. Like if it is hyperkalemia, bring down the potassium levels. If it is hypothermia, elevate the core body temperature. So you have to treat the underlying cause. Second, yes, there are few drugs which can stimulate the heart like adrenaline, noradrenaline, dopamine, vasopressin. They are known to stimulate the heart. That is why whenever someone arrests, we keep giving adrenaline to stimulate the heart. They are capable of. Not my touch, not loud one's touch, not your CPR, and not electrical shock. In fact, electrical shock reduces the chances of stimulating the, right? I hope the message is loud and clear so that we will not do these mistakes in our practice. So then what is the objective of giving CPR? So while I'm trying to identify why heart stopped and I'm trying to get it rebooted by giving adrenaline and trying to treat the underlying cause, by the time heart gets rebooted, the patient's brain will be gone because brain is oxygen dependent. It can sustain for hardly few minutes of lack of blood flow. So to keep the brain and other vital organs, most important is brain only, to keep the brain alive during the period when heart is not working, we pump the chest so that we can push the blood to brain. So the objective of CPR is to eject the blood from the ventricle to the brain when heart is not actually contracting. So we are kind of replacing the ventricle's contraction by our compression. So that is why when we do CPR, the depth of compression has to be at least 5 centimeters. If I'm not pushing 5 centimeters down, I'm not generating sufficient ventricular compression so that blood reaches brain. So merely doing this in the regular CPRs, you are only doing your exercise for the triceps. You're not giving the blood to patient's brain. So even if patient's hearts recover later with your adrenaline and treating the underlying cause, by the time his brain will be gone. So he will be now a brain dead individual. So make sure that when you're doing CPR, you do it effectively so that brain can be kept alive. What is effective CPR? The depth of compression should be at least 5 centimeters. Rate of compression should be 100 to 120 per minute. Only then you will be able to keep the brain alive. Clear? So in arrhythmias, we are giving shock with the hope that once I switch off the whole heart, when the recovery happens, the normal pathways take over and we will have established normal sinus rhythm. Okay. So that is the first point to learn. Second point is, though shock is the best treatment available, it is reserved for two circumstances. Circumstance number one, hemodynamically unstable patients. Circumstance number two, where drugs and other measures have failed. Okay. So when I get an arrhythmia, first thing that I should see, that's a standard template. Because if the patient is hemodynamically unstable, it is always shock. There is no role of drugs in a hemodynamically unstable patient. The mainstay of treatment will be shock. So whenever I get an arrhythmia, I should see whether patient is hemodynamically stable or not. So if I get a patient with PSVT, let us say I got a patient with PSVT, then I have to see whether he is hemodynamically stable or unstable. Now, how do I define hemodynamic stability? By looking at the BP. If BP is less than 90/60, that means he is hemodynamically unstable. So this patient should be given shock. Shock is the only way I can treat this patient. I should not waste my time on the drugs. But if the patient's BP is more than 90/60, that means he is hemodynamically stable. Here I can take steps. Here I can try physical measures. Here I can try drugs. If they fail, then I come back to shock. Then again, when we are giving shock, there are two types of shock. One is called as cardioversion. Cardioversion. And the second one is called as defibrillation. Defibrillation. Can anybody tell me what is the difference between the two, cardioversion and defibrillation? Cardioversion and defibrillation. In cardioversion, we give the shock to the R wave. So if this is the ECG, in cardioversion, I give the shock to R wave in cardioversion. In defibrillation, I can give the shock anywhere. I just don't bother which wave I'm giving the shock. I give shock anywhere in case of defibrillation. Now, why this disparity is important? So cardiovascular is generally followed for most of the supraventricular arrhythmias. Defibrillation for ventricular fibrillation and pulseless ventricular tachycardia. We'll understand the concept behind this. But before that, let me ask you a question. Which one is most dangerous? Is it ventricular arrhythmias or supraventricular arrhythmias? We have discussed this in the previous class as well. Supraventricular arrhythmias are relatively less dangerous. Ventricular arrhythmias are more dangerous. Why? Let us say ventricular fibrillation versus atrial fibrillation. In atrial fibrillation, atria is not contracting. In ventricular fibrillation, ventricle is shaking, not contracting. Which one is dangerous? Of course, atria shaking, not contracting. What is my loss? I am losing passive filling, active filling. Passive filling, 70 to 80% of the ventricular filling is still happening. But in ventricular fibrillation, ventricle itself is not contracting. So there is no ejection of the blood from the ventricles. So zero ejection means zero pulse, zero blood going to your brain. So you are almost on the verge of death, right? If I do not recognize and address it within seconds to minutes, you're gone. So ventricular arrhythmias are more dangerous. Okay. Now, how many of you have heard this term called as commotio cordis? Commotio cordis. Many times boxers, right? Upon a punch to the chest in the ring, they just collapse and die. The moment punch to the chest, they fall there and they are no more there. What happens? So first part of the T wave, right? This is called as the vulnerable period of T wave. Why? Because T wave is the wave of repolarization of the ventricle. A blow to this T wave can impair the repolarization, right? And trigger a ventricular arrhythmia. It can trigger a ventricular tachycardia or ventricular fibrillation. So if you are unlucky, you are in a boxing ring or a cricket pitch and ball or the punch hits your chest exactly when you are in the first part of the T wave, it can trigger a VT or VF, and VT or VF are very dangerous, especially VF, you are dead in seconds to minutes. This condition is what we call as commotio cordis. A blow during the vulnerable period of the T wave can trigger ventricular fibrillation and lead to death. And if punch can do that, what if I give shock here? Shock to the T wave, that can also cause the same thing. Whether it is punch, ball hitting your chest, or me giving shock, it can cause same thing. So if I had a relatively safer arrhythmia, which is atrial fibrillation, and I gave shock to the T wave, I convert that to ventricular fibrillation. A relatively safer is now converted to fatal arrhythmia. Do I want to do that? Of course not. So what I should do if I have supraventricular arrhythmias, I want to give shock away from this vulnerable period of the T wave. And when I want to give away, what is the most easily recognizable wave which is away from the T wave? That is R wave. That's why we give it to R wave. R wave, we do not have any enmity against R wave. We are giving it to R wave because we don't want to give it to the vulnerable period of the T wave. So in cardioversion, shock is given to, it is synchronized to R wave, synchronized to R. In defibrillation, it is asynchronous. I don't have to synchronize with any wave. I just give the shock. So where do I follow this defibrillation? I follow for ventricular fibrillation and pulseless VT. These are the only two arrhythmias where we follow defibrillation. So in defibrillation, I don't have to see where is R wave, where is P wave, just skip. Why? Because the most dangerous rhythms which I'm worried about are already there. So I will just silence this whole activity, hoping that the normal sinus rhythm comes back after this. But if I had a relatively safer arrhythmia like PSVT or atrial fibrillation or atrial tachycardia, then I do not want to convert them to VF. So that is why I have to give it to R wave, away from the P wave. Now, how do I achieve this synchronization to the R wave is another question. Because like we saw a patient with the heart rate of 200, right, one ECG, which was a narrow complex arrhythmia means supraventricular. PSVT, it was 200. So in that case, humanly, is it possible for me to shock the R wave? Like, are my reflexes so good enough that I can see the monitor, and then when R comes, just before it is about to come, I press the button and the shock will be delivered perfectly to the R wave? It is humanly impossible. Then how do we do? So when you see the defibrillator machines, right, there will be a knob for cardioversion and defibrillation. So you have to set the knob to cardioversion if you have to go for cardioversion. You have to set the knob for defibrillation if you have to go for the defibrillation. Rest of the job machine does. If I press a button, but if I've chosen cardioversion, then the machine will wait to identify an appropriate R wave and it will deliver the shock to R wave. If I have chosen defibrillation, the machine will just deliver the shock the moment I press the button without trying to identify R wave. So it is done by machine, but the choice whether I should go for cardioversion or defibrillation is done by me. Clear? Okay. So now you should tell me, if I have a hemodynamically unstable PSVT, should I do cardioversion or defibrillation? So only two conditions we do defibrillation, that is VF and pulseless VT. So here it will be cardioversion. It will be cardioversion. So any arrhythmia whose BP is low, we give shock, it is going to be cardioversion except these two conditions. Remember, pulseless VT, even VT where pulse is felt, we go for cardioversion. Okay. Now coming to the other side, if the patient is hemodynamically stable, then I do not jump for the shock, because shock is little cruel to patient, right? It's not comfortable. I need to sedate and then give shock. Instead, I will try to take more milder steps. So step number one, or first step, when I get a PSVT, PSVT generally tends to respond well to stimulation of the vagus nerve, right? What is the impact of vagus nerve? Vagus nerve slows down the heart rate, right? So I can use that method. I can try to stimulate the vagus nerve. We will call whatever physical measures we do to stimulate the vagus nerve as vagal maneuvers. What I can do as vagal maneuver, I can do Valsalva, or I can do carotid massage. And there are a lot of other variations of Valsalva which can be followed. I can either do carotid massage or ask the patient to do Valsalva. Hopefully that may terminate the rhythm from PSVT to the normal sinus rhythm. If that happens, well and good. My personal experience is that most of the times the rhythm terminated so bounces back quickly. So if that happens, I have to go for the second step. What is my second step? It is pharmacotherapy. Second step is pharmacotherapy or drugs. So then comes the question, what is the drug of choice for PSVT? So the drug of choice for PSVT is adenosine. Only thing we have to remember here is that one type of PSVT, which is AVRT, right? AVRT can get converted to VT or VF if I give adenosine. So we should always, before giving adenosine, we should have the defibrillator ready if that happens, so that we can shock. So do not give adenosine without the defibrillator stand. If I do not have the defibrillator, what else I can use? There are plenty of other drugs which can be used. So if I am giving adenosine, it should be IV. Its half-life is just 6 seconds. So that's why we have to choose a vein which is closer to the heart, right? You can use a brachial vein, or if you have a central line, you should prefer giving central line, right? It is IV through brachial vein or central line. I personally would prefer the central line. And then because it has very short half-life. Why it has short half-life? Because adenosine, right? It is part of your ADP, ATP, AMP and all. So tissues will take it up. It may not reach the heart. Circulating blood cells and tissues will take it up. Before it reaches the heart, it is all gone. So to make sure that it goes to heart, after giving adenosine, right, we should have a 20 cc saline push. So it is basically like, okay, add adenosine to the blood and then push it to go towards the heart. Otherwise, it is not going to go to the heart. Other tissues will take it up. Now, what is the dose that I should be giving? The dose that we use is, the first dose is usually 6 milligrams. And we can repeat 2 more doses. The second and third dose can be of 12 milligrams. So cumulatively, how much we can use? 6 plus 12 plus 12. That is 30 milligrams of adenosine can be used before considering that it failed. It failed. If that fails, all right, what is my third step? My third step is to go for cardioversion. Third step is cardioversion. So in a hemodynamically stable patient, I come to cardioversion if my physical measures like Valsalva and carotid massage and pharmacotherapy fails. But hemodynamically unstable patient, directly I go for the cardioversion. Okay. Now, another question that I have to address here is, what can be used as an alternative to adenosine, and when do I need alternative to adenosine? I need alternative to adenosine if I do not have a defibrillator in my setup. Because if it is AVRT and if I have not recognized it as AVRT, I'm presuming it to be AVNRT type of PSVT, then I can precipitate a ventricular fibrillation, which is more dangerous for life. Right. Second thing is, there are certain contraindications, particularly adenosine is known to cause bronchoconstriction. So if patient is already having COPD or asthma, it can worsen their condition. Their heart may not kill them, but severe asthma attack or significant worsening of the bronchoconstriction in COPD can kill them. So in such cases, it is better avoided, right? So that is also another important MCQ that they can ask you. Contraindications for adenosine. So it is mainly asthma and COPD. So in such cases, what can be my alternatives? What I can use as alternative to adenosine? So I can use the non-dihydropyridine calcium channel blockers as alternative to adenosine. That is another MCQ. Alternatives to adenosine. So I can use either verapamil, which is a non-dihydropyridine calcium channel blocker, or diltiazem, or we have a broad spectrum antiarrhythmic, which is amiodarone. So these can be used as alternatives to adenosine. In circumstances where adenosine use is not possible or it is contraindicated, we can use these drugs. Okay, so I hope the management of PSVT is clear. Simple. All arrhythmias, the same protocol. Unstable, shock. I have to make a choice whether cardioversion or defibrillation depending on the arrhythmia. If it is VF or pulse-based VT, defibrillation. For everything else, cardioversion. Stable, if there are physical measures proven to be effective, try doing that, like in this case of PSVT. If not, then directly go to the pharmacotherapy. Drugs, when drugs fail, ultimately it is shock again. Okay. So that is my approach to PSVT. Next, atrial fibrillation. Now, atrial fibrillation is little peculiar chart. Why? PSVT, we usually put word P behind it, right? What P stands for? SVT stands for supraventricular tachycardia. It can be AVNRT or AVRT. P stands for paroxysmal. Kiran Sangpal, yes, you can use digoxin for, like, okay, I'll come to that. P stands for paroxysmal. Paroxysmal means intermittent. So most common cause for PSVT is AVNRT, which often causes intermittent arrhythmias, because this AVNRT will be triggered when a premature atrial contraction happens and then this arrhythmia gets triggered. Okay. But can PSVT be sustained? Quite unlikely. It's not like, okay, patient presents with PSVT, our drugs fail, right? And then patient will remain in PSVT for months or years together. But there are two arrhythmias which are very often sustained. The most common sustained arrhythmia is atrial fibrillation, and the second most common sustained arrhythmia is atrial flutter. Now, what do I mean by sustained? I can get atrial fibrillation now, and then I can carry this atrial fibrillation. My rhythm will be fibrillating atrial fibrillation for weeks, months, or years together. Same applies to atrial flutter. And because these are sustained arrhythmias, they stay with us for days, months, or years, they bring additional challenges. Apart from the palpitations and hemodynamic instability, they bring additional challenges. What additional challenges they will bring? Let us think of atrial fibrillation. So in atrial fibrillation, atria are not contracting, right? They are not contracting. They are merely vibrating. So when they are vibrating, some part of the atria, especially the left atrium, that to the left atrial appendage, which is the gravitationally most dependent part, whatever blood that is staying in this part, right, is not mobilized. When atria contracts, right, all this blood gets mobilized to the ventricle. But now this gravitationally dependent part, because atria is not contracting, passive filling is not taking this blood, it is stagnant there. And then there was this person called as Virchow, who had said that if there are three things, it increases the risk of formation of a blood clot, right? What are the three things he had said? What you call as Virchow's triad? Virchow's triad had number one, stasis. Number two, endothelial injury. Endothelial injury. Okay. Number three, hypercoagulability of the blood. So when these three things are there, they increase the risk of formation of a clot. So here, out of those, one of the component I am providing, that is stasis. So with this, the stagnation of the blood, it can turn into a clot. So when I have atrial fibrillation, I can develop a clot in the left atrium, which is little less likely in case of PSV. But same in if I have atrial flutter, then also I can develop a clot in the left atrium. Now if I develop a clot, Polival, I have not noticed your queries, but if you shoot it here, I will try to address. Okay. So if I have developed a clot, what is going to be the fate of this clot? What is going to be the fate of this clot? Where it can go from the left atrium? From the left atrium, its natural path is to go to the left ventricle. From the left ventricle to aorta, right? From the aorta, because the axis is well aligned, it goes into the carotids. From the carotids to the brain. From the brain, if it goes and gets stuck in one of the small blood vessels of the brain, which is most likely middle cerebral artery, I can develop a MCA stroke. So atrial fibrillation and atrial flutter are associated with increased risk of stroke. So first point that we learn about atrial fibrillation is there is increased risk of stroke. Okay. And who is preventing this clot from going to left ventricle? Yes, one of them is mitral valve. Who else is preventing this clot from going to the left ventricle? It is atrial fibrillation itself. Means this atria is not putting any pushing force, right? It is not contracting. It is not trying to push this clot to the ventricle. But if I do shock or give medications and convert this rhythm to normal sinus rhythm, it was atrial fibrillation, it was vibrating, shaking. Now I have converted it to sinus rhythm, it will start contract. So once it starts contracting, it will push the clot to the left ventricle, and that increases the risk of stroke. That increases the risk of stroke. So then what should I do? Should I keep the patient in atrial fibrillation state? Because if I convert to sinus and if there is a clot, the clot can get embolized and patient can have stroke. So of course, having palpitations is better than not having one side of the body not working, right? But then if I keep the patient in atrial fibrillation, I have another problem. What? With increased heart rate, right? In atrial fibrillation, the heart rate is high. So with increased heart rate, your ventricles are contracting at higher rate. So when ventricles are overworking, what happens to the amount of oxygen and blood supply they need? Of course, that also increases, right? If I'm running, my muscles need more blood supply. If my heart rate is contracting, heart is contracting at higher rate, it needs more blood supply. If I'm not able to appropriately compensate, right, the myocardium starts becoming dysfunctional. It starts becoming dilated. It leads to dilated cardiomyopathy. So if it is long-standing, right, long-standing atrial fibrillation is associated with is associated with risk of what we call as tachycardiomyopathy. It is called as tachycardiomyopathy. And tachycardiomyopathy is nothing but a form of dilated cardiomyopathy. It is a form of dilated cardiomyopathy. So once the ventricle becomes dilated, its force of contraction comes down, ejection fraction comes down. So now I will get into heart failure. So if I try to treat, I run the risk of stroke. If I don't treat, my heart fails. So what should I do? Well, there are a few points to take note. Of course, I want my patient to be in the normal sinus rhythm, but without the risk of stroke. So how do I achieve? Why clot happened here? The clot happened because of stasis. So it needs some duration of stasis before clot can form. And that duration is around 48 hours. So if atrial fibrillation is less than 48 hours, unlikely that there will be a clot. So in that case, nobody is stopping me from converting this rhythm from atrial fibrillation to sinus. But if duration is more than 48 hours, there is a possibility that there is a clot. And if I convert to sinus, there is embolism and stroke. So that is why whenever we get a patient with atrial fibrillation, right, we have to first decrease stroke risk by anticoagulation. I can take two things. Either I can give aspirin or anticoagulants. Whether to give aspirin or anticoagulants, that will be decided by a scoring system known as CHA2 DS2 VASC score. I have to check the score to decide whether aspirin is enough or I have to start anticoagulants. That is to reduce the stroke risk. Okay. Second, of course, atrial fibrillation will have an underlying cause, right? So I have to treat that. Underlying cause, I have to treat that. Like for example, you might have heard of this term called as holiday heart syndrome. It's like when holidays are announced, friends gather, binge drink heavily, and after that they come back to hospital with palpitations. So alcohol is known to trigger atrial fibrillation. So in that case, I have to make sure that the patient doesn't drink further so that atrial fibrillation doesn't get triggered or sustained, right? Okay. Now coming to that management of the atrial fibrillation per se. So next thing I have to see is what is the duration of the atrial fibrillation. If duration is less than 48 hours, then it is quite unlikely that there will be a clot sitting in the patient's left atrium. So then what would be my strategy? Convert this to sinus rhythm, right? Get rid of this atrial fibrillation. Convert this to sinus rhythm. So when I convert it to sinus rhythm, we will call that strategy as rhythm correction strategy. But if duration is more than 48 hours, or even if it is unknown, because in unknown case, I don't know whether it is of more than 48 hours or less. If it is more than 48 hours, there may be a clot in the left atrium. If I convert it to sinus, there can be risk of stroke, right? Anand, the effectiveness of adenosine is much higher. And if you have, see, the 95% of PSVT are AVNRT. So I'm only worried about those 5% where adenosine may convert it to, like if it is AVRT, it may convert it to a ventricular tachycardia or ventricular fibrillation. So the chances are less, first point. The second point is that even in that 5%, a postgraduate trained clinician can even recognize the AVRT versus AVNRT, because AVRT typically happens because of an accessory path. It's like in patients with the WPW syndrome. So WPW syndrome, ECG has characteristic findings. I can recognize it. So I'm in that 5% also, I'll be able to recognize 3 or 4% of those cases as AVRT. So the risk of mismanaging is for only 1% patients, right? There also, if I have a defibrillator ready, that is significantly minimized. But in terms of efficacy of converting the PSVT or AVNRT to the normal sinus rhythm is higher with adenosine. That is why adenosine is considered as the drug of choice. In clinical practice today, adenosine is not very commonly used. Most of us stick to amiodarone because it is wide spectrum. Even if it is a misdiagnosed some other arrhythmia, it still kind of covers. So that's why we use amiodarone today. Okay, so if duration is more than 48 hours or if it is unknown, I do not want to take the risk, then I cannot directly go for the rhythm correction strategy. Then what I should do? I should do an echocardiography to see whether clot is there. If clot is there, then I should not convert this atrial fibrillation to sinus. If clot is not there, then again I can convert it to sinus, right? So I have to do an echocardiography. But the problem is, where is the positioning of the left atrium? If you have dissected the chest and seen the heart, you notice that most of the right atrium is visible to you when you cut open the chest, right? But left atrium is positioned more posteriorly, right? Only little bit is visible anteriorly, it is positioned more posteriorly. So if I put an echo probe on the chest, I may not be able to visualize well, particularly the left atrial appendage where a clot is more likely to form. So my transthoracic echo is not a good investigation to identify or rule out the left atrial clot. So then what is the best way? We put an echo probe into the esophagus, and through the esophagus we can clearly visualize, from the esophagus we can clearly visualize the left atrial appendage, whether there is a clot present or not. So preferred investigation to identify the left atrial clot will be transesophageal echo, TEE. And if the transesophageal echo tells me that there is no clot, then there is no worry about inducing a stroke. So again, I will follow the rhythm correction strategy. But if the transesophageal echo shows that there is a clot present, then what I should do? Because this clot can now embolize if I convert the rhythm to sinus. But if I leave it like that, patient will develop tachycardiomyopathy, right? So what I can do? So our solution for this problem is, number one, I do not convert the rhythm to sinus, but I will keep the ventricular rate reduced so that tachycardiomyopathy risk is reduced. So this strategy, we will call it as rate control strategy. Rate control strategy. Now what drugs I can use to keep the ventricular rate reduced, but still atrial fibrillation persists? So that for that I can use beta blockers. These are the preferred agents. Beta blockers will control the rate without converting the rhythm to sinus. Or I can use verapamil or diltiazem, like non-dihydropyridine calcium channel blockers. But I should not use amiodarone or any other antiarrhythmics which are known to convert this atrial fibrillation to normal sinus, because then I may run the risk of stroke. Okay. So these can be used. We will call it as rate control strategy. So tachycardiomyopathy risk is reduced, right? But still there is a clot in the left atrium. So even if atria is not pushing, the clot itself can fragment, come down to ventricle and then cause stroke. So of course I do not want that to happen. So that's why we will have to anticoagulate this patient. The next step is anticoagulation. And if I anticoagulate, the clot mostly disappears by 3 weeks. Now you may be thinking, sir, how anticoagulation makes clot disappear? Anticoagulants stop clot from growing further. Anticoagulants are what? These are, see, remember, when a clot is formed in the body, when there is an endothelial injury, let us say this is a blood vessel we're talking about, the inner lining is endothelium, right? And Virchow had said that endothelial injury causes increased risk of formation of a clot. Why? Because endothelial injury leads to exposure of von Willebrand factors, and these von Willebrand factors will lead to platelet adhesion, because they have receptors, they will come and bind. And once the platelet adhesion happens, these platelets send platelet attractant chemicals, which are nothing but thrombexin A2. You know, aspirin acts as an antiplatelet because it inhibits thrombexin A2. And adenosine diphosphate, ADPs. What they will do, they will bring more platelets to the site. This step, the first step where exposure of the von Willebrand factor resulted in platelet coming and binding to it, is called as platelet adhesion. After that, more platelets are recruited to the site, then we will call it as platelet aggregation. So with this, a platelet plug is normally formed. This is how clot formation starts. Now this platelet plug is not a robust structure. This platelet plug will be washed by the blood pressure within few minutes. So to make this a robust structure, we put a mesh of fibrin. So first step in preventing blood loss is platelet plug formation, which had two steps, which is adhesion and aggregation. And after that, we have fibrin formation. The steps involved in fibrin formation, right, through intrinsic or extrinsic pathway is what we call as the coagulation cascade. So if I use drugs which block the platelet plug formation, we will call it as antiplatelets. For example, we have aspirin, clopidogrel, right? These are all antiplatelets. The drugs that block fibrin formation, we will call them as anticoagulants, like your warfarin, heparin. They all inhibit, see, warfarin in this fibrin formation. Fibrin actually exists in the form of fibrinogen that gets converted to fibrin. Now, for me to achieve this, I go through multiple steps through intrinsic or extrinsic pathway following several factors, right? So warfarin, being a vitamin K antagonist, inhibits factors 7, 9, 10. So by inhibiting these factors, ultimately what I am doing, I am preventing fibrin formation. So any drug that prevents fibrin formation will be called as anticoagulants. Now, when I created this, I have created a clot. I have sealed the blood loss from happening from the site of endothelial injury. So behind this, the repair mechanism will start repairing the endothelium. And once the endothelium is repaired and sealed, should this clot stay there? No, this clot should now go because it is an obstruction unnecessarily to the flow of blood. So how will I make this clot go? So nature has given us a mechanism. There is a fibrin dissolving enzyme present. Dissolving enzyme, which is plasmin, which exists in the form of plasminogen. This plasminogen gets converted to plasmin once the clot needs to be dissolved. This conversion is carried out by tissue plasminogen activator. So if I give drugs to block platelet plug formation, they are antiplatelets. If I give drugs to block fibrin formation, they are anticoagulants. But what are thrombolytics or fibrinolytics? The drugs which break down the formed fibrin. They are nothing but tissue plasminogen activator or their analogs, which work same as this. So naturally existing plasminogen, these drugs convert that to plasmin. The plasmin will go and break down the fibrin. So once the fibrin is cleared, the clot is gone, right? So can anticoagulants dissolve the clot? No. What anticoagulants do? They will stop further accumulation of fibrin. But once we have stopped that, naturally this system will get activated and will dissolve the clot. All I have to do is stop more fibrin from being added, then this plasminogen will get converted to plasmin and break down the fibrin. So how many days of anticoagulation is required for the clot to naturally disappear? It takes around 3 weeks. So we do anticoagulation for 3 weeks. So by 3 weeks, the clot will be almost gone. So after 3 weeks, clot risk is, presence of clot is no more a concern for us. So now can I convert the rhythm to sinus? Yes. So if I get a clot in the left atrium, what do? I give anticoagulation for 3 weeks. During this 3 weeks period, to make sure that high heart rate doesn't put the patient at risk of tachycardiomyopathy, I will control the rate. And once the 3 weeks of anticoagulation is done, then I go for the rhythm correction. That is converting the rhythm to sinus. Then we go for the rhythm correction. Okay, I hope the point is clear. So in case of PSVT, we didn't bother much about clot because it is paroxysmal, not sustained sufficient enough to trigger a clot formation. So we will only look at hemodynamic stability and decide to convert the rhythm. In PSVT, our goal is always to convert the rhythm to sinus. Hemodynamically unstable shock, stable, try to give vagal maneuvers or medications. When they fail, go for shock. But in atrial fibrillation, I run the risk of having a clot. So that's why I have to look at the duration. If duration is sufficient enough for a clot to form, I have to do an echo to see whether the clot is there or not. If clot is there, I should not jump to the conversion of rhythm to sinus. I should first control the rate, anticoagulate. By 3 weeks of anticoagulation, clot will probably disappear. After that, convert the rhythm to sinus. But if there is no clot or duration is less than 48 hours, which is generally not sufficient for a clot to form, then I can directly go for rhythm correction strategy. Okay. So rate control, how do we achieve? We know, right? I forgot to mention the rate control can also be achieved with digoxin. So in today's practice, we do not prefer to use digoxin because of its toxicity, right? We have better drugs which can give me the same result. So we prefer to use beta blockers or non-radiotropin calcium channel blockers over digoxin. Okay. Now coming to how do I achieve the rhythm correction? Rate control we understood, right? I can use beta blockers or non-radiotropin calcium channel blockers or digoxin. But rhythm correction for atrial fibrillation, whenever we are going for rhythm correction for AFib, that again depends on hemodynamic stability. If BP is less than 90/60, what is my default choice? Whenever there is a patient with BP less than 90/60, shock. If it is an arrhythmia, shock is the way to treat. So of course I will give shock. What kind of shock? Except VF and pulseless VT. For all other arrhythmias, cardioversion is the way to go forward. Kiran, I'm coming to that point. And if BP is more than 90/60, that means patient is hemodynamically stable. I will not jump for the cardioversion. What will I do in that case? Right? In that case, my approach is going to be vagal maneuvers generally do not help atrial fibrillation, so we'll directly go with the pharmacotherapy. So currently considered drug of choice is amiodarone. This can convert the rhythm to sinus. But the challenge with atrial fibrillation, right, that is what Kiran pointed out. Atrial fibrillation is challenging. Why? Because this is the most common sustained arrhythmia. So many a times the cardioversion fails, the drugs fail. We're not able to convert it. Even when circumstances are that I have want to convert it to sinus, there is no clot, duration is less than 48 hours or it's more than 48 hours, but there is no clot, or it is 48 hours. We found that there is a clot, we gave anticoagulation, clot is gone. I'm trying to convert it to sinus. Many times our attempts fail. It will remain in atrial fibrillation despite giving medications or despite giving shock. In that case, what we can do, right? So that is what we will address now. So if we are dealing with atrial fibrillation, the point to note here is AFib is the most common sustained tachyarrhythmia. AFib may fail to convert to sinus rhythm despite optimal pharmacotherapy or cardioversion. So such cases pose challenge, right? So what challenges they pose? So here I will introduce few terminologies to you before I tell you how to manage such cases where our initial attempts to convert the rhythm have failed. Okay. So if it is AF of less than 48 hours duration, we generally call it as paroxysmal atrial fibrillation. Anyway, how to manage it, we know, right? I have no concern. I will directly try to convert it to sinus. If it fails, next step, of course, paroxysmal AF. If there is AF of more than 1 week duration, then we will call it as persistent AF. It is called as persistent AF. And if there is AF of more than 1 year duration, then we will call it as long-standing persistent AF. Long-standing persistent AF. Okay. So in these patients where despite our effort, AF is persisting for weeks, months, or years, what I can do? So in such cases, generally what we do is we have more approaches. So if we're dealing with persistent or long-standing persistent AF, which is refractory to pharmacotherapy, or instead of calling it as refractory, I will say failed rhythm correction strategy. With failed rhythm correction, we could not achieve sinus rhythm. What I can do? So in such circumstances, I have two choices. One, I can do electrophysiological study. Most cases around the pulmonary vein entry into the left atrium is where ectopic foci are situated. They are constantly fine. I can ablate it. So electrophysiological study and ablation is one approach where I can get this rhythm normalized to sinus, hopefully. So that is one choice. Electrophysiological study and ablation of whatever is the focus responsible for arrhythmia. Of course, many places expertise for doing it is limited, or patients cannot afford it, or they are not willing. So in such cases, what I can do? I will let the patient live with atrial fibrillation, but I will try to manage the complications of atrial fibrillation. What are the complications? Two: stroke risk, tachycardiomyopathy, right? So in that case, I have to stroke prevention and rate control For rate control, as I've already discussed, I will use beta blockers or digoxin or non-dihydropyridine calcium channel blockers. And for stroke prevention, whether I should use aspirin or the anticoagulants, I will decide based on what we call as CHA2 DS2 VASC score. Now, Kiran was asking me how long. If it is atrial fibrillation where rhythm correction has failed and patient remains in atrial fibrillation for a long period, that is chronic AF. In such cases, as long as patient is in atrial fibrillation, he has to be on anticoagulation. If he is in atrial fibrillation for 10 years, he should be on anticoagulation for 10 years. If he carries atrial fibrillation till his death, he should be on anticoagulation till his death. Because if I withdraw anticoagulation when atria is in fibrillation, a clot will form. Somewhere he will have an embolism and stroke, right? Clear. Now, the conditions where EPS achieves the rhythm to normal sinus rhythm. Good for the patient. He does not require long-term anticoagulation or anything, but that can also fail. Normal sinus rhythm achieved, good for the patient. But if that fails, what I should do? Normal sinus rhythm not achieved. In that case, we will follow the same strategy that I was following here. I will come to that, Karan. We will follow the same strategy that I was following. That is, I can't do anything now, right? Whatever best treatment I have tried, nothing worked. So then I will try to minimize the damage by preventing the stroke and controlling the rate. So when we fail or we give up on converting the rhythm to sinus and we will just accept that, okay, patient is going to live with atrial fibrillation. Such cases, it is called as permanent AF or accepted AF, right? So that is one more terminology you should be familiar. Permanent AF. What is permanent AF? Rhythm correction is no longer pursued. We are not trying to correct the rhythm. No longer pursued. AF is accepted. Whether I have accepted at this level or after a failed EPS doesn't matter. Once we have decided that we are not going to chase the atrial fibrillation anymore for its conversion to sinus, we will take it as it is. Then we call it as permanent AF. Permanent AF. So this is permanent AF, where we are giving up, and this is also permanent AF, where we are giving up if the patient is not going for the EPS and ablation, right? Clear? So what is permanent AF? Permanent AF is where patient has given up, or doctor has given up, or mutually we have given up, that we cannot convert it to sinus. We will not chase it anymore. We will just try to manage the complication, that is stroke prevention and rate control. So then Kiran was asking, what is the anticoagulation of choice and how do I decide whether aspirin alone or anticoagulant, right? So for that we are following this CHA2 DS2 VAS. This in itself is the mnemonic. Basically, if these features are there, there's a high risk of stroke. So that calls for anticoagulation. If these features are probably not there, then the stroke risk is relatively less. So we'll try to manage with aspirin alone. Okay. So what is this CHA2 DS2 VASC stands for? C here stands for chronic heart failure or congestive heart failure, CHF. H for hypertension. A, there are two A. That's why it is called as CHA2. Two A's. Both are about age more than or equal to 75 and age 65 to 74. So if it is more than 75, we are giving 2 points. That is 2. Okay. Then D stands for diabetes, S for previous stroke, V for having vascular disease, having a peripheral vascular disease or any other vascular pathology. Another A is for age 65 to 75, for which we are giving 1 point. And then the gender. If it is female, we give 1 point. You can kind of ignore this gender category. I'll tell you why. Just concentrate on the other parameter, or you can simply remember it as CHA2 DS2 VA. Sex category is not important. Okay. Here, two parameters are receiving 2 points. What? One is age more than or equal to 75, right? That is A2. Second one is stroke, S2. Stroke. If you already had stroke, then the chance of having another stroke is much higher. So we'll give 2 points. So for every patient, we will calculate this score based on his history and examination findings, and then we have to decide. We will follow the American Heart Association guidelines, which say that the score more than or equal to 2 for males or more than or equal to 3 for females calls for anticoagulation. If the score is less than this, aspirin alone is enough. So if the CHA2 DS2 VASC score, right, if it is less than 2 for males and less than 3 for females, less than 2 for males means 0 or 1 and 0, 1 or 2 for females, then we will treat them with aspirin alone as a stroke prevention strategy. But if the CHA2 DS2 VASC score is DS2 VASC is more than or equal to 2 for males or more than or equal to 3 for females, then it needs anticoagulation. Anticoagulation. Okay. Why I told you to ignore this gender? If you ignore this gender, basically you have to remember 2, right? Whether it is male or female. If gender point is ignored, because in this 3, one is coming from the gender itself. So if I ignore gender in the CHA2 DS2 VA score, if I get 2 points or more, it calls for anticoagulation, right? Now the question is, what should be my anticoagulant of choice? It depends on other factors. In the sense, if patients, like for example, mitral stenosis is one of the risk factor for atrial fibrillation. So if it is because of a valvular heart disease, especially of rheumatic etiology, or if patient has non-bioprosthetic valve, that is metallic valves replaced, in such cases we have to stick to warfarin. Now the current literature says that for other conditions where it is not a rheumatic heart disease or patient has got valve replacement but it is not metallic, it is bioprosthetic valves, right? In such cases we can go ahead with the newer oral anticoagulants like apixaban, zimilgatran, dabigatran. Those are equally effective as warfarin, much safer, and when we give warfarin we need to monitor the INR regularly. That headache is not there when we are using newer oral anticoagulants, or what you also call as direct acting oral anticoagulants. But two conditions, rheumatic heart disease and patients with the metallic valves or non-bioprosthetic valves in them, we need to give warfarin only. Now you are asking, if you are asking why warfarin only, it doesn't mean that newer anticoagulants are not effective in those circumstances. As of now, we do not have robust studies comparing warfarin versus newer anticoagulants saying that newer anticoagulants are at least equal to warfarin. We don't have studies. In the near future, probably we will have studies and we will probably phase out warfarin from our practice for atrial fibrillation prevention, and we will start using Novax for everyone. But for now, when in the exam they ask anticoagulant of choice, anticoagulant of choice, the point to note is if it is RHD or if it is post valve replacement with non-bioprosthetic valves, basically metallic valve, non-bioprosthetic valves. In these two circumstances, I am going ahead with warfarin. We'll go ahead with warfarin. And for others, newer oral anticoagulants or NOACs are preferred agents. They are going to be preferred for their safety profile and efficacy. They are good. Here, because we do not have the studies comparing NOACs vis-a-vis warfarin, we are still sticking to the proven drug, which is warfarin, knowing that it has side effects, knowing that I need to constantly monitor the INR. I don't have a choice. Still, studies exist comparing it. So it's going to take a couple of years more before we phase out warfarin from these circumstances, right? So let me summarize our management of atrial fibrillation. So if I get a patient with atrial fibrillation on the ECG appears as narrow complex tachyarrhythmia with absent P waves and varying RR interval. Once I recognize that, for the management, I have to look at the duration. If it is less than 48 hours duration, it is basically a paroxysmal AF. The clot and stroke risk is less, so I will directly go for the rhythm correction strategy. But if it is more than 48 hours duration or duration is unknown, there is possibility of a left atrial clot and a stroke risk. So in that case, I have to assess further. So for that, I have to look at a transesophageal echo. If there is no clot, again, I will convert the rhythm to sinus. If there is clot, I have to anticoagulate for 3 weeks. Till that period, I will follow a rate control strategy by giving drugs which do not convert the rhythm to sinus but control the ventricular rate so that tachycardiomyopathy is prevented. And after the 3 weeks of anticoagulation, I step into the rhythm correction strategy. Now, how will I correct the rhythm? Depend on the BP. If it is low BP, it's always shock, that is cardioversion. If BP is fine, I can use anti-arrhythmic drugs. Currently, we prefer using amiodarone. Now, when I try to convert the rhythm to sinus, I may not be able to achieve it in all cases. So when I fail to achieve it, then I have to redesign my strategies, and I should be aware of these terminologies. If it is less than 48 hours duration, we call it as paroxysmal. More than 1 week, it is called as persistent. If it is more than 1 year, it is called long-standing persistent. So in these persistent and long-standing persistent patients, we have to either go with the electrophysiological study and ablation, or there are also surgical procedures to isolate this pulmonary vein entry points from which generally atrial fibrillation get triggered. If it happens, good. If it fails, I don't have a choice. Or if patient cannot afford or it is not technically feasible to go for surgery or EPS ablation, in that case, we have to accept that this patient is going to live with AF. In that case, we call it as permanent AF, where rhythm correction is no longer being pursued by doctor and patient. Such cases, we focus on stroke prevention by anticoagulation. The decision about aspirin alone or the anticoagulants is primarily taken by looking at the CHA2DS2 VASC score. If it is 2 or more than 2, ignoring the gender point, we have to start them on anticoagulants. Now, underlying cause becomes an important factor here. If patient is RHD or if he has undergone a valve replacement with a metallic valve, I have to go with only warfarin. If these conditions are not there, then I can probably use newer oral anticoagulants, and that will take care of the stroke risk. But to make sure that he does not develop tachycardiomyopathy, I still need to employ the rate control measures using beta blockers or digoxin or non-dihydropyridine calcium channel blockers. So that is going to be our approach to atrial fibrillation. This CHA2DS2 VASC score has been asked repeatedly as an MCQ, so I want you to be aware of it. Okay. So the last arrhythmia that I will address today is the management of atrial flutter, and it is pretty easy to remember. Atrial flutter, how do we identify on the ECG? This is also a narrow complex tachyarrhythmia. It's a narrow complex tachyarrhythmia with morphologically distinct P waves being present, number of P waves being more than the number of QRS. And the P wave, because the number is way higher than the QRS, it will give a sawtooth appearance to the baseline. And here also we can express the ratio of P and QRS as 3:1, 4:1, right? 2:1. So if for every 2 P waves there is 1 QRS, I will call it as 2:1 atrial flutter. If for every 3 P's there is 1 QRS, I will call it as 3:1 atrial flutter. For every 4 there is 1 QRS, I will call it as 4:1. Why that happens? Because when atria keeps sending the electrical impulses, AV node has a refractory period. So it will not be able to pass down every signal coming from the atria to ventricle. So there will be a block at the level of the AV node because AV node has a refractory period. So that's why ventricular rate will be lesser than the atrial. That is a crucial point for diagnosis of atrial tachycardias, including atrial flutter. So once I've recognized it as atrial flutter, the point to note about atrial flutter is that it is the second most common sustained tachyarrhythmia. Means it can be chronic, it can stay for long. Sustained tachyarrhythmia, just like atrial fibrillation. So the management of atrial flutter follows the same pathway as atrial fibrillation. So because it is sustained tachyarrhythmia, there is increased stroke risk and there is also increased risk of tachycardiomyopathy. So we follow the same algorithm, right? So management is similar to atrial fibrillation. So whatever we discussed earlier for atrial fibrillation, you can apply it for the atrial flutter as well. See, Kiran, I didn't get your last question. You're asking me how can I prevent development of dilated cardiomyopathy in patients with atrial fibrillation or sinus rhythm. So if you're talking about sinus rhythm, dilated cardiomyopathy is a broad term. Under that, there are thousands of causes. It can be because of chronic alcoholism. It can be because of other drug abuses. It can be familial, for example, titin gene mutation. So I cannot have one preventive strategy. If you say, sir, can I prevent alcohol-induced dilated cardiomyopathy? Yes, it is possible by abstinence, right? Quit alcoholism and at least progression, or if it has not started it, you can prevent the onset of dilated cardiomyopathy. If it is familial, it is not preventable. If you have titin mutation, eventually you will develop dilated cardiomyopathy. So those patients we only treat by treating it as any other case of heart failure or eventually with the cardiac transplantation. Okay. Now, how do I manage multifocal atrial tachycardia? Multifocal atrial tachycardia is a pathognomonic arrhythmia of COPD. If the COPD disease activity is controlled, multifocal atrial tachycardia will come down. So it's like specifically trying to manage the underlying cause. Otherwise, if it is hemodynamically unstable, by default, any arrhythmia, shock is our way to treat, right? So I hope that addresses. I would suggest you to solve some MCQs on these topics, primarily focusing on PSVT, atrial fibrillation, and atrial flutter from the apps. So that in the next class, we will go through some MCQs on these topics, and then we will discuss about the wide complex tachyarrhythmias, that is ventricular tachycardia and ventricular fibrillation. So that's it for today. I'm signing off. I'll see you tomorrow. I think the class will be scheduled on 30th or 31st. I'll see you in the class. Till then, have a good time. Bye. See you guys. Bye.